Welcome to week 2, students. We are going to be covering neurodevelopmental disorders this week. Neurodevelopmental disorders manifest early in childhood development. Onset is usually before entering grade school, and there can be a range of developmental deficits. They can vary from specific limitations of learning or control of executive functions to global impairments of social skills and or intelligence. Characteristics of neurodevelopmental disorders impact 4 specific areas of functioning, and that's personal, social, academic, and occupational impairments of functioning. Neurodevelopmental disorders are comprised of intellectual disability, communication disorders, autism spectrum disorder, attention deficit hyperactivity disorder, specific learning disorders, neurodevelopmental motor disorders, including tic disorders there. And it's important to note that in the DSM-5, all neurodevelopmental disorders give providers the option to capture a specifier associated with a known medical or genetic condition or environmental factor. And hopefully this allows for us to better gather more information on the prevalence of different medical and genetic and environmental conditions that lead to neurodevelopmental disorders, these etiological factors. And by capturing that data, hopefully we can make new headway in genetic research because of that. There have been few studies examining neurodevelopmental disorders as a whole. And so at present, you will see large fluctuations from area to area, country to country, in the prevalence rates of NDDs in the child-adolescent populations. There's also a known underdiagnosis of NDDs in developing countries. So there's a huge need for secondary intervention in public health fields and educational fields in order to minimize socio-emotional consequences, prevent academic failure of our children, and reduce the economic costs to societies globally. Specific to the United States, we do know that rates of developmental disorders are lower than in actuality. At present, we have an estimate of about 15 to 20% of the child population being affected by NDDs. That's between the ages of 3 to 17 years. We will discuss several specific neurodevelopmental disorders, the first being ADHD, which is characterized by impaired levels of attention, disorganization, and/or hyperactivity and impulsivity. The inattention and disorganization create an inability to stay on task, to be able to listen. Frequently, patients will report losing materials, important items, and that would be at a level inconsistent with their age or their developmental level. Hyperactivity and impulsivity entails overactivity, fidgeting behaviors, inability to stay in their seat, intruding on other people's activities, and an inability to wait their turn. And these symptoms would be excessive for their age or developmental level as well, inappropriate to their age or developmental level. While we don't have much current data on the prevalence of neurodevelopmental disorders as a whole, we do have information on these specific individual disorders. So here you can see prevalence estimates for ADHD, particularly in children between the ages of 3 to 17 within the United States. So it would be interesting for you to look at this and see if you can find your state and where you fall in prevalence rates for your adolescent population. It's important when talking about neurodevelopmental disorders such as ADHD to highlight all of the different etiological factors that play a role in the development of that disorder. So here you can see neurobiology, environment, substance use, brain structure, genetics, perinatal exposures, and medical and psychiatric comorbidities, all playing a role in the presentation of these attention disorders. So let's talk and consider a little bit this familial disorder significance. And we know that there is significant risk associated when you have a parent or first degree relative with ADHD or a history of ADHD. Genetic studies have identified specific genes with polymorphisms that are associated with this disorder. We know that stressful psychic events, disruption of the family equilibrium, or other anxiety-inducing factors could contribute to that initiation and perpetuation of this disorder. There are certain predisposing factors such as the child's temperament to also consider, and the demands of society in which that child is being reared. That is a huge consideration as well. The DSM-5 made some changes to ADHD diagnosis. The symptoms must be present by age 12 years now. It was previously 7. The subtypes, previously there were 2, were replaced by 3 very similar specifiers. So the first being combined presentation, then predominantly inattentive presentation, and predominantly hyperactive impulsive presentation. The DSM-5 allows comorbid ADHD and ASD diagnosis. And for adolescents 17 years and older, only 5 symptoms are required. Previously, it was 6 of either category. Here are some screening tools that you can utilize in your child-adolescent patients. When we talk about narrowband screening tools, those are screening tools that focus on the core symptoms of attention deficit hyperactivity disorder. Then when you talk about broadband screening tools, it's not only assessing or screening for attention disorders, but it's also assessing multiple behavioral conditions. Let's talk about medication management for ADHD. While psychotherapies are very beneficial, medication management is oftentimes necessary in these pediatric patient presentations. So if you choose to utilize a stimulant, that is identified by 2 different groups, the methylphenidate-based group or your amphetamine-based group. If the children or adolescents do not have any known cardiac risks, then this is a great option for them. And if at all possible, utilizing sustained release, extended release options is favored because that means that's only once daily dosing and it minimizes rebound side effects. Those rebound side effects are irritability issues, potentially sleeping issues at bedtime, other mood instability, anxiety, rebound anxiety. So let's talk about some of the most, or just highlight very briefly, some of the most common methylphenidate FDA-approved medications for children and adolescents. That includes your Adhancia XR, your Asteris, Concerta, Focalin, Focalin XR, Daytrana, Jornay PM is a great new one, Metadate, Methylin, your Quilichew, your Quilivent, your Ritalin long-acting. Then you've got your amphetamines, that's your Adderall XR, Adzenys, Dexedrine. It's going to include Vyvanse and even Mydayis, which is another wonderful option. You have non-stimulant options if there's hesitancy or contraindications for stimulants. That includes norepinephrine reuptake inhibitors such as Strattera or Qelbree. Qelbree is one of our newer medications, and it is outperforming Strattera in the latest research. When you are talking about not utilizing stimulants and potentially utilizing antidepressant classes of medications, then remember to highlight the black box warning for your patients and their families, because there is a potential that drugs like atomoxetine could increase suicidal thoughts or behaviors. If you are utilizing stimulants, keep in mind that you could end up with secondary sleep disorders such as insomnia that then needs to be managed. So for that, you might have to tie in adjunctives such as melatonin, hydroxyzine, diphenhydramine, low-dose trazodone. You could even tie in alpha-adrenergics there so that you could treat the difficulties falling asleep and staying asleep. That includes guanfacine, clonidine, and even those other symptoms of hyperactivity, poor focus, restlessness. All of those things can be treated with alpha agonists as well, such as clonidine and guanfacine. One thing to keep in mind is that other antidepressants, such as Wellbutrin, could potentially increase irritability or induce hypomania or mania in your pediatric patient populations. So it can be utilized, but there's been variable success with it in the treatment of ADHD specifically. We could talk at length about ADHD management, but instead I've just provided some extra resources that on your own you can explore. It includes psychopharmacological and non-pharmacological treatment resources. Moving on to autism spectrum disorder. It's characterized by persistent deficits in social communication and social interaction across multiple contexts. That can include deficits in social reciprocity, nonverbal communicative behaviors used for social interaction, and skills in developing, maintaining, and understanding relationships. In addition to the social communication deficits, the diagnosis of autism spectrum disorder requires the presence of restricted, repetitive patterns of behaviors, interests, and/or activities. This shows prevalence estimates by gender from a 2020 sample of 8-year-olds specifically from 11 different US communities. And it shows that autism spectrum is more commonly diagnosed in boys. And when I say more commonly diagnosed, the question of accuracy of prevalence is up for debate because it has been thought that diagnoses are going missed for girls. And here you can see the prevalence of autism spectrum disorder worldwide, globally, from country to country. And you will see that the United States carries a high prevalence as opposed to other countries. And I'll note here that autism spectrum disorder is an abnormality in brain structure and function, and there is emerging evidence, a large body of evidence, that genes play a role in this, and that there is a genetic variable to autism spectrum disorder. And so those cluster of unstable genes that get passed down somehow lead to the abnormality in brain structure. And precipitating events or causal events that lead to development of autism spectrum disorder could include infectious, neurological, metabolic, immunological, or even environmental issues. So a lot to think about and many different variables at play in the development of this disorder. Autism spectrum disorder has a distinct symptom triad. That includes impaired social interaction, impaired social communication, and restricted repetitive behaviors. Identifying that triad allows you to differentiate autism spectrum disorder from other comorbid diagnoses. For instance, ADHD is characterized by a triad of inattention, hyperactivity, and impulsivity. So if you hone in on that, you can have a comorbid diagnosis of ASD and ADHD without truly knowing the core features or the core symptoms of these disorders. The comorbidities go under-recognized. So I would like to highlight that autism spectrum disorder frequently occurs in association with other medical disorders and mental health disorders. That could include Fragile X, epilepsy, developmental syndromes, tuberous sclerosis, Turner syndrome, metabolic disorders like PKU. It could include ADHD, OCD, depression and anxiety disorders, especially in higher functioning autism spectrum patients. Depression and anxiety may be the presentation of it. So you have to really hone in on your assessment skills to identify the underlying diagnosis. And then there's other psychiatric disorders as well. Psychosis can accompany it. These are all things to keep in mind as you perform your new intakes, your patient assessments, and move forward with follow-up medication management and treatment for your established patients. Here are available screening and diagnostic tools for your pediatric patients. You can identify developmental delays utilizing those developmental screens. You have autism spectrum specific screening tools and then diagnostic tools for autism spectrum disorder. We already highlighted the core features for DSM-5 criteria of autism spectrum, but I do want to highlight that you can specify severity, levels 1, 2, or 3, based on the degree of support necessary to the patient. And you can also specify whether or not the ASD is with or without accompanying intellectual impairment, language impairment, known medical or genetic condition or environmental factor, or if it is associated with another neurodevelopmental, mental, or behavioral disorder. And you can also specify if it is associated with catatonia. So lots more options in the DSM-5 updates in how you can capture these diagnoses. It's also important to keep in mind that imaging plays a role in diagnostics of any known medical or genetic conditions, or even environmental factors precipitating diagnosis or leading to development of ASD. It's important to include hearing and visual screening in your medical assessment, speech and language evaluation, occupational and physical therapy evaluations, reviewing growth milestones, and psychoeducational testing, potentially EEGs, and then lab assessments to identify any medical or genetic or environmental causes. If your medical workup has identified any other accompanying medical disorders such as tuberous sclerosis, leukodystrophy, Fragile X, Rett syndrome, DeGeorge's, Prader-Willi, the list goes on, so on and so forth, then certainly you need to manage the medical manifestations of those disorders. Then psych management for the associated presentation of autism spectrum disorder shifts to honing in on individual symptoms such as irritability, aggression, self-injurious behaviors, anxiety, depression, sleeping issues. So let's review some different options that are FDA approved for pediatric patients. You could utilize Risperdal or Abilify for that irritability and aggression. Self-injurious behaviors. There are increased side effects with Zyprexa usage, particularly weight gain in pediatric patients. So if possible, I would stay away from that. Risperdal actually happened to perform better in studies for youth anyway, so definitely a good initial medication to go to. Remember to monitor prolactin levels in male youth on Risperdal, however. If you're looking for mood stabilization, you can utilize Depakote, Lamictal. Antidepressants to utilize could be Prozac. Remember your black box warning with these antidepressants. Celexa was significantly more likely to be associated with adverse events in studies that are available, particularly increased energy levels, impulsiveness, decreased concentration, hyperactivity, insomnia, and all of those. If you had a comorbid attention disorder diagnosis, that would be not beneficial to the whole outcome. And studies also show that repetitive behaviors in autism spectrum disorder were better treated with Prozac anyway. There's also other medications such as amantadine and naltrexone that could be utilized. And also refer back to the potential stimulant and non-stimulant uses for symptoms presenting similar to that in ADHD. Again, there's so much information to cover, and I've provided just some extra resources to you that at your leisure you can go through and review on your own. In the DSM-5, Rett syndrome is associated with autism spectrum disorder, so you can specify it as a form of autism spectrum disorder. Rett syndrome carries a worldwide prevalence of 1 in every 20 to 40,000 people. It is one of the most common genetic causes of developmental and intellectual impairment in girls specifically. There is a distinct loss of function mutation in the MECP2 gene on the X chromosome, and it affects up to 1 in every 10,000 girls under the age of 12. It's not a neurodegenerative condition. It's a progressive disorder that involves multiple systems and symptom evolution over time. There are similarities in Rett syndrome to other developmental encephalopathies. At this time, there is still no peer-reviewed, consensus-based therapeutic guidance for treatment of this disorder. So treatment is really based on what specific symptoms or behaviors need care or focus. And recently, the FDA approved trofinetide for children ages 2 years and older. It works by reducing associated swelling in the brain and increasing the amount of protective protein in the brain, stopping some of the cells from becoming too active. What we know is that we must continuously monitor for physical health pathologies in these girls with Rett syndrome, such as breathing difficulties, scoliosis, cardiac pathology, seizures, movement disorders, and occupational therapy, physical therapy, wearing of braces, utilizing mobility devices, engaging in water therapy. All of those activities can be helpful in treatment and management of the symptoms. Many individuals with Rett syndrome live into middle age and beyond despite those symptoms. And unfortunately, because the disorder is so rare, very little is still known about the long-term prognosis and life expectancy. Now we'll wrap up with intellectual disabilities and specific learning disorders. Intellectual disability is characterized by deficits in general mental abilities such as reasoning, problem solving, planning, abstract thinking, judgment, academic learning, and learning from experiences. The deficits result in impairments of adaptive functioning, so the individual ends up failing to meet standards of personal independence and social responsibility in one or more aspect of daily life. That can include communication, social participation, academic or occupational functioning, and personal independence at home or in community settings. Here you can see the prevalence of developmental intellectual disability worldwide. Of note, the prevalence is higher in lower income and middle income countries. That difference is hypothesized to be due to decreased access and decreased quality in maternal child health care facilities, perinatal screening methods, and so on. ID presents with impairments in general mental abilities within 3 different domains: conceptual, social, and practical. Conceptual speaks to reading, writing, language, mathematics, knowledge, memory, problem solving, and judgment. Social encompasses awareness of others' thoughts, feelings, experiences, social judgment and understanding, interpersonal communication skills, and social problem solving. Practical encompasses self-management across different life settings, including personal care, personal responsibilities, transportation, finances, school, work organization, and occupational skills. Specifiers for ID can fluctuate anywhere from mild to profound, and that's based on the level of functioning, not IQ scores. Etiology varies from genetic predisposition, environmental insults, and developmental vulnerability, particularly in the prenatal and perinatal phases or time frames. Fragile X is one of the most commonly inherited syndromes resulting in ID that results from a repeat variant in the FMR1 gene on the X chromosome. Single gene disorders include neurocutaneous syndromes such as tuberous sclerosis or neurofibromatosis, chromosomal or copy number variant disorders that result from either an extra copy or a missing copy of an entire chromosome or chromosomal segment, such as the 3 autosomal trisomies, 13, 18, and 21, trisomy 21 being Down syndrome and being one of the most common genetic causes of ID. Risk factors exist for co-occurring psychiatric disorders as well, such as ODD, ADHD, and ASD. That includes severity of cognitive, adaptive, language impairments, socialization deficits, low family socioeconomic status, trauma, and even having a single biological parent as a caregiver. Regarding pregnancy and after, during pregnancy, maternal malnutrition, vitamin or mineral deficiencies, placental insufficiency, in utero exposures, including alcohol, drugs, toxins, or even teratogens, maternal illnesses such as hypothyroidism. I want to highlight fetal alcohol spectrum disorders as one of the leading cause of preventable developmental disabilities in the world. Pre- and perinatal infections can also affect the developing fetus directly. That's through things such as toxoplasmosis, syphilis exposures, varicella zoster, even rubella, CMG, and herpes exposures. During delivery itself, asphyxia is the most important risk factor for brain damage leading to ID. Prematurity and low birth weight, intracranial hemorrhage, hypoglycemia put infants at increased risk for brain damage, leading to ID, placental insufficiency, and intrauterine events during labor and delivery, such as eclampsia, premature rupture of membranes. All of those could lead to hypoischemic, encephalopathic events, and subsequently ID. Then in age ranges from toddler to child to adolescent and beyond, brain trauma, near drowning, and other accidents that result in loss of consciousness can cause brain injury. Infections such as meningitis and encephalitis during these timeframes could also lead to permanent brain damage. And even poisoning from lead and other substances could do the same, and that could eventually lead to ID. Here are some screening tools to identify developmental delays in pediatric populations. If you have a positive screen, that should be followed by diagnostic evaluation. You can utilize instruments specific for determining intellectual and adaptive impairment. And assessment tools for co-occurring mental health disorders should also be utilized. Treatment for ID is very similar to that of our other neurodevelopmental disorders, where you treat the presenting symptoms, the most problematic symptoms requiring our focus. So common medications utilized in our pediatric population are Risperdal, methylphenidate, clonidine, and melatonin for associated symptoms. Communication interventions are huge and play a large role in treatment outcomes and health outcomes long term. And building up school and community support can make all of the difference. Now we'll discuss specific learning disorders. Specific learning disorders present during school age years. It's estimated that 10% of youth have a specific learning disorder. It's diagnosed when there are specific deficits in an individual's ability to perceive or process information efficiently and accurately. The specifiers include with impairment in reading, with impairment in written expression, or with impairment in mathematics. It's important to rule out hearing and visual impairments. There is a high comorbidity with ADHD, communication disorders, developmental coordination disorder, ASD, and mood and anxiety disorders. It's characterized by persistent and impairing difficulties with learning foundational academic skills in those three specific domains, reading, writing, or math. The individual's performance of that affected academic skill is well below average for their age or below acceptable performance levels, or it requires extraordinary effort to achieve those acceptable performance levels. Treatment here focuses on remediation strategies or the adjunctive treatment of other comorbidities and the symptoms related with those disorders, for instance, attention disorder. Finally, some extra resources specific to ID and SLD for you guys to review at your leisure. Thank you all for following along with this week's lecture.